Good evening, everybody. We're going to dive off in tonight about behavioral emergencies. We're going to try to keep going. I got some stuff I got to do later on, so I'm going to try to knock this out. It's not a whole super long class, so we should be good to go and having everything done pretty well. Everything's recording. All right, so diving off into this again. Here's your the National EMS Education Standards. We know that the medicine, it has not changed from the last slide for the first slide, so they're all the same. So tonight we're going to go over psychiatric emergencies, basically behavioral emergencies. We'll talk about basic principles of mental health system, assessment management of acute psychosis, suicidal risk, agitation or agitated delirium. So as you see here, most of our patients we've experienced as we go through EMS are going to have some type of health crisis. We're going to see these more often than we're probably used to on a daily basis. Every now and then you may see that one or two persons that have a mental issue as you're walking through here or there. We try not to stare or look. That's just something that we don't want to add into. We teach our kids the same thing, but at the same time in EMS, we deal with this. I would probably say it's a 60-40 split between mental and health illnesses versus a medical true emergency call. So you'll see these a lot out there. What's it say? At some point, most people experience emotional crisis. This does not mean everyone develops into mental illness. It's just mental crisis and illnesses are completely different. Otherwise, healthy people may sustain acute and temporary mental health disorders, but do not jump to conclusions that patients may have that may be mentally ill just because they're having a mental crisis. It may depend to where you have a traumatic issue in your family. You may be dealing with a death. That we all have these that we just can't function or stand or are able to handle at that minute, but we're able to recoup from that. We're able to make better decisions as we move on. We don't have to worry about long-lasting issues from that. Now, I mean, some do have those life-altering experiences that change, and then they turn around and have these mental illnesses that last forever. So the most common misconception about mental illness is that if you're feeling bad or depressed, you must be sick, and that's not true. There's so many justifiable reasons about feeling depressed. You can have divorce, a loss of job, death of a relative or friend. I mean, it could be within the home. This is all normal reactions to an acute crisis. Now, just remember, that is the word. It's acute crisis because it's not a lingering, long-lasting effect. This is something that's recently happened and that we have to deal with on the fly. Sorry about that, it's coming across the screen. Some people believe that all individuals in mental health disorders are dangerous. They're not dangerous, violent. They are manageable. You just have to know how to deal with each particular person that's dealing with that crisis. Only a small percentage of people with mental health problems fall into these categories. EMTs may be exposed to a higher portion of violent patients because they are seeing people who are by definition considered to be having a behavioral crisis. We have to communicate with these people, but in some cases, patients will de-escalate what the level of trust is established. So the quicker we're able to distinguish a level of trust, a good open line of communication, a lot of these high tense situations can decrease because we've built that good confidentiality, and the situations do de-escalate. Although you cannot determine what caused the patient's crisis, you may be able to predict whether the patient may become violent. Watching their hand movements, watching their eyes, watching their body motions, just several things out there. Stand by. Just watching their overall gestures, their movements, that is something that we see. That is something that we may deal with. So those are some of the ones that we have to deal with. Is the violent tendency is what we have to be careful for in EMS. Those are the ones. Hold on 2 seconds. All right, sorry, I had to get a message out. All right, so behavior crisis is what you see in a person's response to the environment, his or her actions. So remember that. So behavior is what you can see of a person's response to the environment, his or her actions. Over time, people learn to adapt to a variety of situations in daily life. This is including stress. Sometimes stress is so great that the normal ways of coping are not enough, or the person uses negative coping mechanisms. Talk about withdrawal, drugs and alcohol. Reactions to stress are acute, and those that develop over time can create a crisis. The change in behavior may be considered inappropriate and not normal by the ones who call 911. We not knowing on a daily basis is something that we're not used to that situation. I'm trying to do multiple things here. So when we get these 911 calls, you hear these frantic on the ends of the patient, this guy's acting crazy. They're doing this, they're doing. So we have to understand that is a person's opinion that they see it. They reflect on what that they're dealing with. A behavioral crisis includes patients of all ages who exhibit agitation, exhibit agitated, violent, or uncooperative behavior who are a danger to themselves or other. EMS is called when behavior has become unacceptable to the patient, family, or community. And a lot of it is too, is just when family can't deal with it anymore. When they have those issues of trying to they're just at their wits end. They can't do this. They're tired of trying to deal with these people. They don't know what else they can do with it. They they have issues just trying to figure out. I don't know. I'm at my limit. I need help, and they turn around and call 911, expecting us to make these immaculate changes, and it doesn't happen. We're just the ones that have to Uber these people to the facility. We have to figure out how to make them work. We have to figure out how to get them there in the safest manner and protect us. Those are some of the things that we just have to deal with, and it's one of those. They teach you, but over time you have to learn more and more how to deal with these patients to where we do it in a safe manner for us all. Usually, if an abnormal or disturbing pattern of a behavior lasts for more than a month, it is a matter of concern and mental health standpoint. When a behavioral health emergency arises, the patients may show agitation or violence and may become a threat to themselves or others. So after about 3 months wise is when you start having, they start getting evaluated. The doctor starts sending them for psychologists, psycho tests. They get different types of treatment, and then after a while they may see that they do an inpatient stay in certain facilities just so they can manage their medication, get their medication on point, and then they can make the changes and go forth from there. Once somebody does these inpatient stays and they get out, what happens is they're on these medications and they don't really have these flare-ups. They don't have the concerns while they're in there because they're on the medication. What happens is when they get out, they get off their medications. They don't take them on a regular basis because they don't have somebody demanding that they come to the tower to take this, to do this, do that. So you start to come off of those highs of the medication that's working, and that's when you start to have all these behavioral crisis outreaches, and you get more of the 911 calls from these houses because they're saying, hey, Fred's over here beating everything up, he's off his medicine. Well, yes, but at the same time, as I don't really blame him for the crisis he's going through, we have to also blame the possible caregiver that is allowing this person to stay with them, or they're the one that's sharing care because they're maybe a minor. because that particular person is not providing the care like they said that they would, as in helping with medication. The magnitude of mental health disorders. According to the National Institute of Mental Health, mental disorders are common throughout the United States, affecting tens of millions of people each year. A psychiatric disorder is an illness with psychological or behavioral symptoms that may result in impaired functions. Anxiety disorders are among the most common mental health disorders. We talk about generalized anxiety disorder, panic disorder, social and other phobias, obsessive and compulsive disorders. They also say PTSD is in this one. I personally believe that PTSD is an overused term to categorize someone, and that is getting, that's like this ADHD. Oh, where they're ADHD. Well, that's a broadcast of a diagnosis so they can treat them and or have it fixed, covered on insurance and all that. Those are just broad categories. The more that you get out there, you'll start to realize, you start to hear all these diagnoses and you're just like, that's not at all. Well, what's going on? That's not the case. So that's just a personal thing that I see, that PTSD is overly used there. Okay, I'm sorry, I just read that one to you guys. So the U.S. mental health system provides many levels of assistance to people with psychological disorders. You do have professional counselors. You have, individual counselors. You may have some parenting issues that they have to deal with. You'll have your psychologist that steps in and handles your more severe. And then your psychiatrist is more of your severe psychological conditions. So you have to remember which one. So you start low with like a counselor, and then you go to a psychologist, and then you go to a psychiatric. Those are the kind of the levels of care of who, they start small and work big. Sometimes somebody may be referred to a psychologist and they need I am just tongue twisted up here. Woo. Then they go see the psychiatrist and they're like, I don't need to treat this patient. And then they can turn around and go see maybe just a professional counselor. They need somebody that they can talk to on a regular basis. And that counselor is the one that they refer them to. They may refer to like a group. They may send them to like a Christian counselors group, or just, they can refer someone else. Most psychological disorders can be handled through outpatient visits, but some of the most severe ones, or some of the most common ones that we deal with, do require hospitalizations and specialized behavioral units. Tamara says, in Louisiana, they pretty much make you go to psychiatrists for depression meds. Now the regular MD won't prescribe them. I think that's more and more common. And the reason why is it's the medication, the DEA that they have to be informed with. It's more of a specialized thing because there's so many different medications out there that just a regular, just go to your normal clinic doctor, that you can broadcast a certain type of medicine, and that may not be specific to what, let's say, type of depression, or you're having to deal with sleep anxiety or things like that. So those are more and more common, Tamara, that you're going to go see a psychiatrist for those situations because they know those heavy medications. And I don't want to say like heavy dosages and all that, but they know more specific of what particular type needs to be prescribed for that particular issues that are going on. So I see that more, not only just in Louisiana, but more and more across the country, that's being going towards as a psychiatrist. And then it fixes kind of a broad cast of things when they do it that way. Behavioral and health disorders have many underlying causes. So we look at social and situational stress, and such as divorce, the death of the loved one. We have disease of schizophrenia, physical illness such as diabetic emergencies, chemical problems such as alcohol or drug use, biological disturbance such as an electrolyte imbalance. Sometimes these conditions are compounded by non-compliance with prescribed medications and regimens. So again, and I point back to the individual because they may not just be taking their medication like they're supposed to. That once they get on these medications, oh yeah, I'm feeling so much better. Well, you're not really better. I don't need the medicines. You're just on a better state because of the medications. And when you stop taking them, you're like, oh, see, I told you I'm something, and you're just so much worse. So it's trying to stay on top of these things is the key point of what we need to do, because they're actually working. These medications are working for these individuals. If we can just get people to understand that and stay on the medications. I know we see a lot of issues now with diabetics, being unable to afford the medication because the medications are high. I mean, it's the same thing as trying to afford $5 a gallon of gas to go get that $80, $90 a month medication. That it's a stress. It's a stress that's on that patient to try to do right, but they can't because it's financially, they're trying to figure out which one's more important, my medication or milk and bread. You know, that's a strain that I hate to see people deal with, but it's more and more common these days. So the pathophysiology is, we're not responsible for trying to figure out what type of attack's going on, or attack or crisis. That's not our job. You just need to understand the two different diagnoses a physician's going to use. It's either going to be organic, which is physical, or functional, which is psychologic. So those are the two things that we want you to try to figure out if they're under the categories. So is it going to be an organic, which is a physical diagnosis, or is it a functional, making us psychological? I say those multiple times, so y'all write those down, and that's going to be more of your ones that you're going to try to use. Organic disorders. So organic brain syndrome is a temporary or permanent dysfunction of the brain caused by a disturbance in the physical or psychologic function of the brain. Some of the causes of that is sudden illness, traumatic brain injuries, seizure disorders, drugs and alcohol abuse, overdose or withdrawal, and disease of the brain such as Alzheimer's disease and meningitis. So that is more related to your organic. Some of the other organics, altered mental statuses can arise from a hypoglycemia, because that's hypo, which is low, and then hypoxia. You can have impaired cerebral blood flow, hyperthermia or hypothermia, and in the absence of a psychological cause, altered mental status may be an indicator of a psychiatric disorder such as bipolar. I know that's a lot. That's the reason why I'm trying to slow down so y'all can sit there and read that and write it down if you guys need to. Does anybody got that? You want me to go back and let y'all write some stuff down, or you tell me? Go back. All right. So I'm gonna leave it right there for just a second. Sydney, you tell me when you're ready. All right, let's go forward. All right, some functional disorders. So psychologic disorders that impair body functions when the body seems to be structurally normal is schizophrenia, anxiety conditions, and depression. So here, I know this is our regular skills and we're going to be cautious and careful, but some of the things we have to remember is just looking at this picture right here, this is potentially a weapon. Obviously he has hands right there. Those are weapons. and we're standing super close. Now, they may have built this relationship to where they can get close, but we need to make sure we take caution. As soon as we walk in, we need to, this brings attention to me, what's the bucket of water or chemical sitting right there in the corner? You see, but you see the device over here and but I don't see any wall plugs. So those are certain things and weird things that stand out to me. And where, like, is this an exit? Is that the bathroom? Well, I need to know my exits. You just need to find those things when you walk in so you can figure out, hey, I'm ready to move forward. I need to go. I need to retreat. What are those some actions? So, and again, when you're standing there talking to these patients, don't stand above them trying to belittle them. You want to try to get eye level or make yourself a little bit, well, right here, make yourself a little bit lower at a 45-degree angle, but be aware this position could hinder your movements. Don't just try to stand over them and make them just feel down. That's the thing that we want to make sure to try to do our best, is to give them the space and all that they can make good educated decisions on their own, and we're not trying to be there and just take them out of their home. This right here may be everything this man owns. Yeah, he's in a bad situation, but this may be everything in the world that he owns, and we're probably fixing to take him to a facility and he's going to lose everything, and that's nerve-wracking right there in its own. So scene safety, the first thing to consider is the scene safety of the patient response to the environment. Is the situation potential dangerous for you and your partner? Do you need immediate law enforcement? I mean, you think about that. Should you stage until law enforcement personnel have secured the scene? What are some of the things that we need to do? What do we need to make sure? What do we need to look for? You need to understand what is going to, in that room or in that area, that potentially is going to endanger me, my health, my safety, my well-being. All of those things is we need to be aware and expect the unexpected. So does the patient's behavior seem typical or normal for the circumstances? Are there legal issues involved? There may be a crime scene. Do we have full consent? Are they refusing our care? Do they say, don't touch me, don't come around? Take appropriate standard precautions or request any additional resources you may need. So I may need law enforcement. I may need some extra EMS there, or I may need fire. If you need them, get them there early. It takes them time to respond to. And now that you've got this patient semi-calm, you're asking for assistance and all that, other people arriving could potentially make this patient ramp back up and be all, be unaware, just be on high alert. They may lose trust with you because you've lost their trust, or they've lost trust in you because they were calm and all that. And then you're calling all these strangers into their home, to their environment, to now help take care of them when they were feeling comfortable enough to take care of you, or you were able to take care of them. So mechanism of injury or illness, note any medications or substance that may contribute to the complaint, or that they may be for treatment or a relevant medical condition. What are my surroundings telling me? Do I see empty pill bottles? Like I've told you before, I always look in the refrigerator. Is this patient a potential diabetic? Okay, well, what kind of medicine are they on? If you notice a refrigerator in their room or right in their immediate reach of where you are looking, and just tell them, they're like, well, what are you doing? Say, I'm looking potentially see if you were diabetic and didn't tell me. I need to know. A lot of people keep them in their refrigerators, and I would like to make sure that if I saw it, I could at least look at it. I'm trying to do everything I can for you. Make those decisions and then let them know what you're just doing to try to figure out what's going on with them. On your primary assessment, we are going to form a general impression. We know we're going to do that as soon as we walk in the door. Our eyes are going to be scanning. Our minds are going to be thinking. We're not making assumptions. We're trying to form general impressions of the patient. Begin your assessment from the doorway, from a distance. Do a rapid physical exam. Observe the patient closely. Use the APU scale to check for alertness. Establish a rapport with the patient. And most medical or trauma situations will include a behavioral component. And what real simple things are, is the patient able to follow simple commands, yes or no? And then you can elaborate on that. Patient was noted to be seated in a seated position on the floor, rocking back and forth, talking to herself. Noted the patient was talking to someone that was not able to be seen on entry into the room. All those things need to go into your report. We're not trying to make somebody's opinion of them change, but that is a big part of what needs to be added into our report, because we may have to use physical restraints further down the road, and those are things that add into our reports that build up the reason why we had to use restraints. You can't just not paint a picture and then say physical restraints were required during transport. But why is the first thing I'm going to ask if I'm QA in your report. Is you didn't discuss, mention, or anything that you needed to have any type of restraints. You didn't say that the patient's behavior was odd at all. Those are some of the questions I'm going to ask. Airway and breathing, are they patent? Is the patient able to maintain their own airway? Did they allow you to use a pulse ox? Were the findings appropriate for what was going on in the situation? Their ABC was open, patient was holding on airway and was able to speak in 1 to 2 sentences without taking a breath. That's a good, quick, rapid assessment. Okay, again, circulation. Assess pulse, rate, quality, and rhythm. Evaluate the presence of shock and bleeding. Assess the patient's perfusion by evaluating skin color, temperature, and condition. You're going to need to note that until you're able to dictate that without, in a normal paragraph sentence or in a report wise, you need to make sure that you do vitals and you list every bit of that out, that you turn around and you list, respirations RR-18, then you do another dash and you list out their respirations, clear, equal, bilateral respirations noted on inhalations, no audible noise heard on inhalation or exhalations. Those need to be broke down every single time you write that report, because you got to build a system. And right now, none of you have a system in writing reports. So building the freshness of a system is going to help you learn how to write. The best thing you can do is read old patient reports that somebody maybe you work with allow you to read some of theirs, or read something from a call that you're on with your partner, and just be like, hey, look, I'm so new into this. Obviously, is there a way that I can read your report when you're done so I can get a better idea on how to write reports when it's my time? Transport decisions. We know this from the get-go. Is this going to be a stay and play, or we need to load and go? Most of the time, our mental patients are going to be a slow process, because we have to either build the trust in them to get into the ambulance and shut the door. Plus, it gives us time to build a rapport, figure out the patient's patterns, pay attention to see if anything is changing or will change during our assessment. So we need to know those before we shut ourselves up in a canned box trying to go down the road. I just want to make sure I understand potentially what's going to be going through this patient's mind and or emotions as we're making it down the road. That's important to me. History taken. Obviously, we know the sample. We want to get as much information as we can from the individual. If we can't, let's talk to the family. And then right here, we need to ask, is there a history of behavioral illnesses? That's important. Okay. If has there been significant life changes, symptoms, or illnesses involved? Are they hallucinating? Are they using drugs or alcohol that you're aware of? And even ask the patient, be like, look, bro, I don't really care if you on drugs, done smoked a pound or what. I need to know if you're on any type of illicit street drugs to where when I give you some medication, it doesn't have a severe reaction and you'll die. A lot of times people will come around and say things like, no, man, I'm not taking it. And you're like, how many times did you try to crank that engine with nom? But you need to understand, what signs and symptoms of street drugs are. You look at that and say, it's just not right. Maybe they'll tell you, maybe they won't. Sometimes you'll find paraphernalia on them. Be cautious, especially if you're searching for anything like needles, open back, anything like that that can possibly contaminate you. Be very cautious in that. Sample history, we know that. You may be able to elect information that would be helpful to the hospital staff. Geriatric patients consider Alzheimer's disease or dementia and use reflective listening. When the patient says, I've been having trouble just breathing, it hurts down in my back, I relay that back to them and say, hey, Mr. Fred, I just want to make sure I'm documenting this right. You're saying that you've had back pain and you have back pain, which is causing you to have trouble breathing, or have you always had trouble breathing and have always had back pain? Well, I just started having back pain, but I've had trouble breathing for a long time. So they know that you're listening to what they're saying. You can do that in a normal conversation too. Anybody works in customer care or support, anything like that, you can say, okay, Mr. Fred, I just want to recap the situation, make sure I understand what your complaint was. And sometimes that validation allows people to understand, be like, wow, they really were listening to me. That's the reason why I try to write down things that the patient is saying so I can keep up with it, and to make sure when I relay it back to them that, yes, that's what I said. That's what I want to make sure I do feel better. I'm okay, and thank you for listening. So it gives them that extra care that somebody does listen. Here's some questions to ask in evaluations during a mental health disorder. Let's hit a couple of these. Does the patient appropriately answer you? Do they answer your questions on a normal basis? Are the patient's vocabulary and expressions what you would expect under the circumstances? And does the patient express disordered thoughts, delusions, or hallucinations? Don't ever go into their hallucinations with them. I know you may think it's funny to say, yep, their spiders are on the wall. It's not when they come at you and try to whoop your butt too. So just don't ever play into their hallucinations. I promise you, it's not a good thing. Your secondary assessment. Now, remember, on these mental patients, and I say acute, let's say of acute issues, they may not allow you to touch them. They may not allow you to get hands-on. Obviously, if it is an unconscious patient, we are gonna, make this pretty quick and fast. We want to rule out if there's any type of trauma to the head. Consider whether prior events such as physical agitation, use of stimulants, alcohol withdrawal, or taser exposure may be contributing to the patient's conditions. Check for track marks in their arms. A conscious patient may not respond to your questions. And definitely, if you say, hey, is there any way that I can put this blood pressure cuff on you? I just would like to know what your blood pressure is. And they tell you no, you know that this right here is not happening. This physical examination is not going to go the way that your mind is planning it to happen. Just not going to work. So that's a safety thing that you also need to be able to respond to, is be like, wow, that's really not going to work. We got to figure something else out. You can tell a lot about a patient's emotional state from facial expressions, their pulse rate, their respirations, or read this right here. What I want you to know: a blank gaze or rapidly moving eyes could mean central nervous system dysfunction. They may have that 80-yard stare everywhere you go, and they follow you and look at you. Be cautious. Be very cautious, because you don't know what their next move is. The quiet ones are the ones we have to worry about. The ones that will talk to you and threatening you, those are the ones that I'm okay with. The ones that don't talk are the ones that are the more nerve-wracking that I've dealt with in my career. All right, so when we get ready to transport, are you comfortable in having this patient in the back of your truck with you by yourself? Do you need particular assistance in this matter? Obviously, if they're having any type of behavioral crisis, they cannot go by air. We need to make sure that we take them to the appropriate facility, and we need to try our best to let the patient know that we're trying to send them in the most position of comfort. Are you comfortable sitting right there? No, I don't want to sit on the stretcher. Well, sir, that's the only place I'm allowed to take you in this ambulance, is because my company, if you won't sit on the stretcher, I can't take you. I would lose my job. And and I'll tell them, I got 4 kids at the house. My wife doesn't work. I don't need to lose my job. Please, can you help me? They don't know. I'm not lying to them about anything about their care. I'm lying about my lifestyle and how I need to make it more safe for me to transport this particular individual. So again, the very top one's the best. Never let your guard down. If restraints are necessary, reassess the documentation and document the patient's respirations as well as a pulse, motor, and sensory functions every 5 minutes. Once you restrain this patient, you need to make sure that you're doing their vitals on a trauma scale every 5 minutes, because now you have restrained this person. Their agitation is going to go through the roof. Their potential respirations, their vital signs, all that's going to change, because now you've taken that free ability away from them to where now they can't do a whole lot, and they're going to be nervous. They're going to be more agitated and potentially aggressive to you. So be prepared and ready for that to happen. If you do any type of interventions to diffuse the situation, note that. Advise med control what you've done to a certain point to diffuse the situation. Some things work better than others. If it is just you being a good listener, be a good listener for that patient. Intervene only as much as it takes to accomplish a task. If you think of a pharmacological restraint is necessary, always request ALS. Because we can't do that as our little basics, but we can have other individuals show up that have those abilities that can start the IV and provide medications. They can add certain things for us to help us out. So if we think that's something that we need or we're going to potentially want, let's get them going early. Communication and documentation. Again, the only thing I can tell y'all most about this is if you didn't document it, it didn't happen, and you can't go back on it and say that it helped you in the long run. If you say the patient struck you, hit you, and you didn't document that, you're still in a whole nother issue there. If restraints are used, say which type and why they were used. Like there's a couple of types of soft restraints that I can think of right off the top of my head. So on that case, make sure you identify, did you use cling wrap or did you use an artificial soft restraint? You need to make sure you call those by name, and that those were put on with assistance of ... As soon as patient was secured for their safety, vital signs were obtained and are listed below. That is a very big documentation point that we need to make sure that is done at any time that restraints are used. Acute psychosis. Psychosis is a state of delusion in which a person is out of touch with reality. Affected people live in their own reality of ideals and feelings, causing psychotic episodes. We have mind-altering substances, intense distress, delusion disorders, and schizophrenia. Schizophrenia is a complex disorder that is not easily defined or easily treated. The typical onset occurs during early adulthood, with symptoms becoming more prominent over time. Influences thought to contribute disorder is brain damage, genetics, and psychological and social influences. Some symptoms are delusions, hallucinations, the lack of interest and pleasure, and erratic speech. Guidelines for dealing with a psychotic patient. Determine if the situation is dangerous. Clearly identify who you are, what you're doing, and what you would like for them to do for you. Be very calm, always direct and straightforward. Never beat around the bush, and don't lie to them, because they will remember and they are probably gonna throw that back towards you. Maintain an emotional distance to where if they have an emotional reaction, that you have time to see that reaction and you have time to act. That's something that needs to be made sure that you have that reflection and distance time, because it's very important to your health and well-being. Never argue with these patients. Never argue with any type of person that's going through acute mental disorder. Again, explain what you would like to do. Involve people whom the patient trusts, such as family, friends, and to gain the patient's cooperations. If they see that family trusts you and that they're able to work with you, a lot of times that they will build that trust and be like, oh, okay, well, he's working with that guy. Maybe I can too. So, and they tend to follow those simple directions. Excited delirium is also known as agitated delirium or excessive mania. Delirium is a condition of impairment in cognitive function that can present with disorientation, hallucinations, or delusions. Sorry, my daughter is walking outside and I was like, what is this reflection? Agitation is a behavior characterized by restless and irregular physical activity. Some of the symptoms of delirium are hyperactive irritational behavior, vivid hallucinations, hypertension, tachycardia, diaphoresis, and dilated pupils. If you think you can safely approach this patient, be calm, supportive, and be empathetic. Let them know that you feel what they're going through. Approach the patient slowly and purposefully and react to the patient's personal space. Allow them to understand that you know, hey, look, I don't want to invade your space, but is there a way that I can potentially check your blood pressure? Will you let me put this on? I don't want that thing on me. Can I show you how it works and then allow me to let you put it on? You can put it on yourself. Limit physical contact as much as possible. Never, ever, ever leave a mental state patient alone. If this patient's like, well, I'm gonna go back in the house and get dressed, somebody has to go with them. And most of the time we at least send one all the way with them and another one that's really close. We never let our partners go super far without us. Use careful intervening to access the patient's cognitive function. Determine the patient's ability to communicate very early. Observe the patient's appearance, dress, and personal hygiene. I want to try to start speaking to these patients as soon as we make eye contact. As soon as we get close enough and I can realize, yes, they are looking at me, bam. Hey, man, how you doing? Sorry to holler at you. I just want you to let you know, hey, I'm Wally with the ambulance, as you can tell. I'm just trying to figure out what's going on, man. Is there a way that you can tell me your side of the story? Just say, hey, well, here, I'm here for you. I just want to make sure that your health is good as all will and all. And then if you see a scratch on their arm, be like, hey, how'd you get that scratch? Can I put a Band-Aid on it for you? I don't want you to get infected. Even though you may know that it's something that you're coming there for a mental crisis, you're starting to build that rapport with that patient early. So that helps. That lets us get out there and they realize, wow, they're not here just for that. Maybe you're building that trust and that rapport with them. If the patient appears to be experiencing an overdose, take all medication bottles or illegal substances with you to the medical facility. Now, I'm gonna tell you, if you see weed, cocaine, crystal meth, and like that sitting there, just take a picture of it. I don't want anybody to get in trouble that they sweeped it in a bag and now they're transporting it to the facility and now they get there and you tell the hospital's police that you're like, hey, look, yeah, they got meth and I got it right here. Wait, what? I'm not saying that they're going to charge you, but just take a picture of it. It's so much easier. We all have phones. So the patient should be transported with a behavioral facility. Do your best to never use licensed sirens unless it is medically warranted for this patient's safety. If you back there, the patient starts to get hostile, tell your partner to pull the truck over, you need some help, and to call for assistance and give them your exact location. If the patient's agitation continues, always request ALS so they can do a chemical restraint. Excited delirium can lead to sudden death from sudden cardiopulmonary arrest. Physical agitation thought from the result of metabolic acidosis. Physical control measures. This includes tasers. If we try to physically restrain them, they work their hearts up. They can go into sudden cardiac arrest. You have stimulant drugs and positional asphyxiation. That's the reason why if we ever physically restrain somebody, they have to be on their back. We can't physically restrain them to the face down on the stretcher. Or, you can use two backboards and squeeze them together. I'm not saying, but tie them to those to where you're creating a barrier, but they have to be face up. We have to be able to see their face, their airway, and their chest rising and falling. If we restrain, so this one's kind of long, I want y'all to understand, so I'm gonna read this one to you guys. Pre-hospital patient restraints reduce the possibility of a patient injury, the potential for injury to EMS providers, and allows for safe and appropriate treatment of an uncooperative patient. The National Association of EMS Physicians recommends that every pre-hospital care transport provider create the following pre-hospital patient restraint protocol. Your company will have these protocols, and you are most likely guaranteed to have to call med control. The appropriateness of restraints, the type of restraints, the care provided to the patient following restraints. Your protocol must consider the laws of your state. Pre-hospital patient restraint protocols vary widely throughout the country. Protocols should include only the use of restraint devices that have been approved by the state health department or the local EMS agency. The method of restraint chosen should be the least restrictive method that will ensure the safety of the patient and the provider. I want to make sure that they're restrained enough to where they're safe and I'm safe, and it's not going to cause any harm as we're traveling up and down the road. Risk associated with patient restraints. Improper use of physical restraints can lead to life-threatening conditions, including positional asphyxiation, aspiration, severe acidosis, and cardiac arrest. Restraint of a person without authority in a non-emergency situation can result in legal actions. You can be charged with assault, battery, false imprisonment, violation of civil rights. That's why I tell you guys, I don't look good in orange jumpsuit, so I want to pick the color if I'm going to end up having to wear a jumpsuit. Always, always, always contact med control if you get to the point to where you need to restrain somebody, and let med control give you the orders for that. Now you have a physician that gave you orders to restrain somebody, and you can do that without getting in trouble. So even these 5-point restraints right here, shoulders and across the abdomen, across the other upper legs and lower legs, those restraints are still some type of physical restraint. Obviously, you see these hand guards right here. This is a soft after-marketed restraint. These will be tied down towards the feet area, and the feet are tied straight down. You see they're trying to struggle to get this arm down to the side. Whenever I try to have one above and one below, because they can turn around and start having trouble with, separating the shoulders and all that. If you go to restrain somebody, you always want one person per limb. So in this particular case, you need 5 people. Majority of everybody needs 5 people, depending on how strong this person is. You're going to have the 5th one controlling the head, 2 for the legs, 2 for the arms, and 1 to control the head. Involve law enforcement personnel if you are called to the assistance to assist a patient in severe behavioral crisis. Prior to using physical restraints, use verbal de-escalation, verbal judo, some of y'all have heard it that way, and try your best to try to diffuse that situation as much as you can with just simple words. Simple, easy words can make a lot of things disappear. The process of restraining a patient. Once the decision has been made to restrain a patient, you should carry it out very quickly. You see right there, ideally 5 people should be used to restrain, 1 person responsible for each extremity and 1 for the head. There should be a team leader who directs the process and plan of action. Use the minimum force necessary to control the patient. The level of force will vary depending on the factors. The degree of force that is necessary to keep the patient from injuring themselves or others, a patient's sex, size, strength, and mental status, to include the possibility of drug-induced states, the type of behavior that the patient is exhibiting. So if you need more, use more, it's okay. It's fine that you need extra help. Get some extra help there. Your partner should talk to the patient throughout the process. The patients treat the patient with dignity and respect at all times. Apologize for what you're doing. Sir, I'm so sorry we're having to do this to you. We just need to make sure your safety is what's taken care of the most. Where the appropriate behavior protection during the patient restraint activities. If the patient's a spitter, put a mask on the patient. Avoid direct eye contact and respect the patient's personal space until necessary. Never leave a restrained patient unattended. 4-point restraints, both arms and both legs are preferred. I have also used a 2-inch roll of tape and secured their chest down because they were bucking like a wild horse. So I used it as I taped it to the stretcher a couple of times and went back and forth across their chest. I didn't make it tight. I just used it to where they couldn't rear up and down and potentially break my stretcher. Respiratory and circulatory problems have been known to occur in combative patients who are restrained. Restraints applied in the field should not be removed until the patient is evaluated at the appropriate facility. Perform patient restraints. There's also a different type of skill sheet that's on 23.1. Sorry, wrong way. The potential for violent patients. Violent patients account for a small percentage of patients undergoing a crisis behavior crisis, if I could pronounce correctly. Assess the level of danger based on the following factors. What's their history? Is this something that's new? Have they gone on this? And then when somebody from the scene be like, hey, y'all gonna want to tie him down early, he gonna get real feisty here in a minute. Listen to them. Let them tell you. The posture. Is the patient sitting or standing? Is the patient tense, rigid, or sitting at the edge of his or her seat? Those are signs to be very cautious because this patient can react and become very violent, and we don't want that. Is the patient holding a potential lethal object? What is their vocal activity? Are they speaking to you, or are they loud, cussing at you? You tell that right there is telling you the tone of the patient and what you need to be prepared for. Physical activity. The motor activity of a person undergoing a psychiatric emergency may be the most telling factor of all. The patient requiring careful watch. A patient requiring careful watch is the one who has tense muscles, clenched fists, a glaring eye, is pacing back and forth, can't sit still, is fiercely protecting their personal space. Those are something that you have to just watch out for, that they probably going to get violent, that they at any minute that they can react and have some issues, concerns, something that's questionable. Poor impulse control, a history of truancy, fighting, and uncontrollable tempers, history of substance abuse, depression, which accounts for 20% of violent attacks. Functional disorders. If the patient tells you the voices are telling him or her to kill, believe it. Listen, if they say, I am going to kill somebody before the day's over with, let's let it not be me. But sir, who's telling you to hear that? And don't be telling them up close, because you never know what they can do, what the abilities these patients have. Take some distance. If they say that and you're up close, take a few steps back. Create a gap. You need about a 6-second gap to where you can react, see something, react, and move. So you need that gap. You need that space. Do what you got to do to gain some distance. If a person is having suicide, depression is the most single significant factor that contributes to suicide. It is a common misconception that people who threaten suicide do never commit it. Threatening suicide is an indication that someone is in a crisis that he or she cannot handle alone. You need to immediately intervene this situation as fast as you can. Assist these patients. Listen to them. Be their advocate to get them some assistance. Be alert to those warnings. Suggestions of suicide, apparently appearing detached from the situation. Specific plans for commuting suicide are related to death. If they relate to the death and they're okay with it and they're comfortable, and they're like, I think, blowing myself up would probably be the easiest, or drowning, because then I can suffer the most, like I've caused all the other ones to suffer. You're like, wait, what, whoa, what's you talking about, bro? Feeling of sadness, deep despair, or hopelessness that suggests depression. Listen to these people. You need to gain as much information as you can, so that way that you can pass the information on to the facility. Once you take them, you can provide all this information, that way that you can get them the best of help that you can. If we don't say nothing, now we're not doing the best for this patient. So here's some risk factors for suicide. I'm gonna let y'all read that real quick.
Huh? Yeah. And the batteries were still good. I can't get logged in. I don't know the password to get logged into the app to see if they'll update.
All right. Consider these additional risks. Is the environment unsafe? Is there an imminent threat of the patient or others? Are there unsafe objects in the patient's hand or nearby? Let's see. Is there an underlying medical problem? What else is something that we've dealt with? Is the family giving us enough information that we can add? We can pick up some different things. Are they telling us what's going on? Now we also have to go back and think about, not currently, but we deal with, veterans, patients returning from war, those type of issues are the ones that we have the most when we start talking about some of our vets that try their best to deal with things and move forward. So when you have these vets that they say these things, they mean these things, they truly are the ones that are saying that, I'm going to kill myself. Believe them. A majority of vets, when they say something, they mean it. And the ones that have, let's say they get a call, like dispatch says, the VA home has called that you need to respond to such and such to check on, a patient. Go ahead and notify and get PD en route with you, because these vets may potentially want to take somebody out with them. They don't want to go alone. They may be in a middle state that it's not okay. We want to do everything we can to try to help get these patients taken care of the best we can. And then sometimes we just need to be an advocate and speak for them. Some of the methodological aspects of EMS are more complicated with patients undergoing behavioral health emergencies. Legal problems are reduced when the patients consent to care. If they say, yes, I need help, yes, I want to go, it's easier for the system to work with you versus you had to take that patient against their will. You had to get med control involved. You had to get law enforcement matters. Because even when the patient gets to the medical facility, they can say, I don't want to be here. They took me against my will. You're more of a liability issue at that point, just because you have to justify, or they can come back and ask questions, why you brought them there. You can do all these things, but you need to make sure that it's appropriate, that you did the right thing, that you had to make these calls for the best of this patient. Once you've detained the patient and has an impaired mental capacity, you must decide whether he or she requires immediate medical care. A patient in a mental unstable condition may resist your attempt to provide care. Do not leave this patient alone. Request law enforcement personnel to handle the patient at that point. Most states, if a patient attempts suicide, or they say that they are, that is a crime against the state, to where law enforcement has to intervene, to where that patient broke the state law, to where then that patient has to be taken to a mental facility and to be evaluated. Not a lot of officers like to intervene in that, because then now it puts them at liability too. But if they say, hey, if you turn around and say, hey, I saw this patient with a letter, the patient told me that they were going to kill themselves once we leave here, and PD doesn't intervene, ask for another agency or ask for, some extra support. Don't leave the patient. Don't leave the scene. You need to get a supervisor or someone else on scene to help you with those decisions. Consent, implied consent is assumed with a patient who is not mentally competent to grant consent. Consent matters are not always clear-cut in behavioral health emergencies. If you are not sure, request the assistance of law enforcement personnel or guidance from med control. If you have any questions, always consider calling med control. Always call med control. Let me say it again. Always call med control. The EMT has limited legal authority to require or force a patient to undergo emergency care when no life-threatening emergency exists. If it is a traumatic situation, I can automatically jump in and take a patient and take them to the nearest trauma facility at my request. I don't have to ask them. But if they are not in a life-threatening situation, we get a little bit more tricky situation. We have to be able to appropriately document what we did that for, or we have to paint a good enough picture to med control to allows us to bring that patient against their will. A competent adult has the right to refuse treatment even if life-saving care is involved. Now, if they are awake, alert, and oriented, and they're bleeding out, and they pass out, and they're the whole time they're saying no, 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 but they do pass out, well, guess what? That's implied consent until they wake up. Once they wake up, because your interventions have helped them, they may tell you to stop. Well, it's too late. You're in a moving vehicle. Sir, as soon as we get to a situation, we'll stop. They'll pass out again eventually. And, by that time, hopefully you're at the nearest facility and be like, help. He passed out. I jumped in. As soon as he woke up, they said that he said he didn't want no help. So he's about to die. He's your patient now. Those situations have happened to me. In a psychiatric case, court case of law, would probably consider your actions in providing life-saving care to be appropriate. A patient who is in any way impaired may not be considered competent to refuse treatment or transportation. Always maintain a high index of suspicion regarding the patient's condition. Assume the worst and hope for the best. Err on the side of treatment and transport. Carefully document the patient's statements and behavioral to support your actions. Anything that you put in the report that the patient says, you need to say, patient stated, question, quotations, ... quotation. Patient stated this. You always need to make sure that it's in quotations in the best exact words that you can to make it to the patient or from the patient. Those can just always help build your case. It's not going to say it's going to make your case more solid, but if there's ever a legal issue later down the road, you've got more documentation than anything else from just your knowledge and knowing, hey, this needs to be documented. This is a tricky situation. That helps build your case up a lot better than just saying, yeah, I remember that call and this is what we did. Well, that's not what we need you to do. We need some documentation. Those things help out the most. It is actually the end of this lecture. We knocked that out pretty well. Did pretty well in this one. Like I said, it wasn't a whole lot. Do you guys and gals have any questions about what we went over tonight or anything in the past? Tamara, I don't know if also I replied to your email. Just to let you know if you hadn't seen it yet. I'm looking at some other emails real quick. Hey, some of my Hattiesburg guys, just to let y'all know, your stuff should be all back and working. You should be able to log in, see things, and start going forward from there. Let me see. Dominique, check your email. I replied to you also. If nobody has any questions, concerns, or problems, I am going to show y'all this screen right here. That's your class code for the night. Don't forget your test unlocked tonight at 10 o'clock. You have until Wednesday, Thursday, Friday night at 11:59 to finish your test. I hope y'all have a great evening. Best of luck to y'all on your test and be safe. We'll talk to y'all Thursday night.